Hi guys, it's a girl Jopek and I'm back with another interesting video. Before we move on to today's video, do you know cervical cancer is the second leading cancer in women? It kills about thousands of women each year. And in today's video, we are about to find out what this cervical cancer entails. About to find out the symptoms, the causes, the mode of transmission, the risk factors, and other important information about this cervical cancer. But before we move on to today's video, if you haven't subscribed to my YouTube channel, go and subscribe now so that you don't miss any video I post on my YouTube channel. We'll start with what cervical cancer actually means. Cancer is the abnormal growth of cells. So, related to cervical cancer is the abnormal growth of cells on the cervix, which is not supposed to be so. You may be wondering what actually caused this cervical cancer. Cervical cancer is caused by the persistent infection with human papillomavirus, HPV virus, which means you can have this HPV virus in your system, but the immune system can automatically clear it from your system if it is not persistent. So that's why we say the persistent infection with human papillomavirus. And with these causes, there are two types. Human papillomavirus does not only cause the cervical cancer, it causes the throat cancer, the cancer of the hands, the vulval cancer, it causes genital warts. But let's find out which type actually causes the cancers I mentioned. With the causes, there are two types. We have the low risk type, then the high risk type. With the high risk type, it causes 95% of this cervical cancer. This high risk can also cause the throat cancer, the pineal cancer, the cancer of the heart, and many other cancers. The high risk, although we have a lot of types, the high risk we have type 64 and so many types. But the most prominent one is the type 16 and type 18, which causes 95% of this cervical cancer. With the low risk, we have type 6 and type 11, which also causes 99.9% of genital warts. That's why I said the HPV virus does not only cause the cervical cancer, because the low risk causes most of the genital warts. Let's move on to the mode of transmission, how it is transferred. With the mode of transmission, we have the asexual means and non-sexual means. Let's start with the asexual means. With the asexual means, we have the manual to genital sex, genital to genital sex, and we also have the genital to anal sex. With the non-sexual means, we have the vertical transmission and we have the horizontal transmission. So with this vertical transmission, it is the transmission from the mother to the child, which causes the child to lose his or her voice. We also have sharing of ball string and others still under the vertical transmission. The horizontal transmission entails of handling of formats such as the door handle, washroom. With the risk factors, we have sex at an early stage. With cervical cancer, it is believed that children from 9 to 14 years should be vaccinated as early as possible before they reach the age at which they can have sex to prevent or reduce the transmission of this cervical cancer, since it can be transferred from boys to girls or girls to boys. The second is smoking. Smoking is believed to damage women's estrogen level. The third is multiparity, having a lot of children at the same time or giving birth to a lot of children at the same time. This damages the strength of the cervix and makes it possible for every virus to enter freely. The fourth is multiple sex partners or a partner with multiple sex partners. Fifth is the prolonged use of oral contraceptives. And the last is poverty and lack of women empowerment. Let's move on to the signs and symptoms of this cervical cancer. The first one is abnormal and offensive vaginal discharge. We have abnormal vaginal discharge tinged with blood, severe pelvic pain, bleeding in between menses, then bleeding in postmenopausal women, postcoital bleeding. That's bleeding after sexual intercourse, which is not supposed to be so. Then we move on to the prevention. We initially have two types of prevention: the primary prevention and the secondary prevention. Let's start with the primary prevention. With the primary prevention, it consists of three things. That's the education, vaccination, and lifestyle modification, especially the sexual lifestyle modification. So with the education, we educate the patient on this cervical cancer. You explain everything she needs to know. Then with the vaccination, you advise them to vaccinate. Even vaccinate the household, because boys and girls can have this HPV virus in their system. The boys, because it's the pineal cancer, then with the girls, the cervical cancer, and both it can cause this hand cancer, the throat cancer, and other types. So you advise them to vaccinate every child to prevent or reduce the risk. So with the vaccination, we have a lot of vaccination, but let's talk about the Gardasil and the Cervarix, since it's the common vaccination right now. With the Cervarix, it protects you against two types. That's the high risk, type 16 and type 18. First dose is counted as 0. Then the second dose is taken 1 month after the first dose. Then the last dose is taken 6 months after the first dose. So it's 0, 1, 6. With the Gardasil, it protects you against 4 types of these viruses. That's the 2 high risk and the 2 low risk. Then with the high risk, type 16 and 18. Then with the low risk, type 6 and 11. And the first dose is taken and it is counted as 0. Then the second dose is taken 2 months after the first dose. Then the last dose is taken 6 months after the first dose. So it is 0, 2, 6, whilst the Severus is 0, 1, 6. With the lifestyle modification, especially sexual lifestyle modification, if the person is able to manage his or her lifestyle affairs, like not having multiple sexual partners, because you don't know who carry this virus, it may transfer to you and you can transfer it to other people. So if this person is advised to modify his or her sexual lifestyle, it reduces this. The second or the primary prevention, it entails with the screening, diagnosis and treatment. So with the second one, if the person comes to you, you screen the person, you observe that maybe they are not lesion. Lesion simply means the white patch on the surface after application of acetic acid. So you diagnose whether there are lesions or not. Then you treat the patient. This leads us to the treatment of cervical cancer. With the treatment, we have 2 types. That's the ablative treatment and the palliative treatment. The palliative treatment simply means the pain relieving treatment where drugs are given. You have the ablative treatment. The ablative treatment consists of 3 treatments. That's the cryotherapy, also known as the cold or freezing method. Then we have the thermal coagulation, also known as the heat method. So with the cryotherapy, it's also known as the 16 minutes because the woman has to lie on her back for 16 minutes. Then you freeze the cervix for 3 minutes, then you thaw for 5 minutes. You freeze for the second 3 minutes, then you thaw for the second 5 minutes. That's why it's a 16 minute approach. Then with the thermal coagulation, it's the 45 seconds to 100 degrees approach. It also uses heat. And with this, the woman has to lie on her back for 45 seconds. With the thermal coagulation, the probe is heated for 45 seconds at 100 degrees Celsius. If it is heated, it is placed on the surface, then it cools off using 45 seconds. And the last one is the borderitomy. With the borderitomy, the patient needs anesthesia because it also uses heat as the thermal coagulation. But this time around, the heat used in the borderitomy is higher than the heat used in the thermal coagulation. That's why the patient needs anesthesia, because the patient can't withstand the pain or the heat until the borderitomy uses. So let's move on to the screening method. The screening method used in cervical cancer. Now the visual inspection method, which consists of the VILI, VIA and colposcopy treatment. With the VIA, the full meaning is the visual inspection with acetic acid. Then VILI, visual inspection with Lugos iodine, and the colposcopy. So with the VILI, Lugos iodine is applied on the surface. And as they say, iodine loves glucose. So the part on the surface containing the glucose will turn black. And glucose does not love protein. So the part of the surface containing protein will turn yellow. This yellow part indicates there is a virus present on those parts which turns to yellow. But with the black part, it indicates that that part does not contain any virus. So with the VIA, acetic acid is applied to the surface. And it is timed for 2 minutes, 2 or 3 minutes. So after this 2 or 3 minutes, if there is any lesion on the surface, it shows that these viruses are present there. Let's move on to the other types of screening method. That's the cytology or pap test. With the pap test, when taking a sample or biopsy for pap test, the question swab is turned once over the cervix or around the cervix. Or you can even take from the ops, that's the mouth of the cervix. This is because pap is specific. So if you turn it more than once and the person starts bleeding, your pap result will come as error. So with the cytology or pap smear, we use the EVA system, that's the Enhanced Visual Assessment System. So we currently have the EVA Pro and other types. Then with the lesions, we have 2 types. We have the major change and the minor change. And the major change or the dense change, the whitish part is very visible. The minor change, it can sometimes be faint. And the major change is also a suspicion for precancerous lesion. We also have the HPV test. And when taking a sample for the HPV test, the cotton swab is turned 5 times around the cervix. This is because HPV is specific. So whether the person is bleeding or not, the HPV results will never read as error. Although we have the screening method, the HIT method, and the blood dieting, we can't use this in certain cases. Cases where we have other abnormal thing on the cervix, like the leukoplakia, that's a white patch on the cervix before application of acetic acid. The ileation is the white patch on the cervix after application of acetic acid, whilst the leukoplakia is the white patch on the cervix before application of acetic acid. So in cases where we have leukoplakia, the blood dieting method can be used. The freezing method can't be used, that's a cryotherapy. It can be used. Thermocoagulation method can't also be used, but we use the excision method, that's the loop method, loop electrosurgical excision procedure. That's what we use when you're handling cases like leukoplakia. So that part is taken off from the cervix. When the healing process begins, the cervix will go back to normal. That's the squamous metaplasia. Let's move on to the transformation zone. Well, the transformation zone is an area between the old squamous columnar epithelium and the new squamous columnar epithelium. We have three types of this transformation zone. We have TZ1, that's transformation zone 1, and we have TZ2, TZ3. Let's start with the TZ1. With the TZ1, the squamocolumnar junction is fully visible and it is ectocervical. It is outside the cervix. You will see the junction between the squamous epithelium and the columnar epithelium. It is believed most women, so when you pick like 10 people who have reached their menopause, just one will have this type of transformation zone. With the TZ2, the full circumference of the squamocolumnar junction is fully or partially visible, but this time around it is endocervical. The TZ1 was ectocervical, but this TZ2 is endocervical. So with the TZ2, sometimes the squamocolumnar junction is in, or sometimes partially. So we have a little columnar junction outside. Then with the TZ3, it is also fully or partially endocervical. The full circumference of the squamocolumnar junction is endocervical or partially endocervical. It's just like the TZ2, but they're a little bit different. So let's move on to some abnormal cervix, or some things which show that this cervix is abnormal. So we have the Nabothian cyst. Nabothian cyst simply means the white patch on the cervix before application of either Lugos iodine or acetic acid. So this Nabothian cyst is not treatable. It goes and comes by itself. You can't do anything to it. And we also have leukoplakia. Like I said, the white patch on the cervix before application of acetic acid. So leukoplakia is treated by excision. We also have leukoplakia, then that's the reddening of the transformation zone. So before anything, transformation zone can be detected after application of acetic acid. We also have polyps. We have bleeding polyps and non-bleeding polyps. So with these polyps, it can bleed after sexual intercourse or it can bleed by itself. Let's move on to the VIA procedure, or the visual inspection with acetic acid procedure. The requirements are speculum, gel, cotton swab, acetic acid. That's the most important requirement. We also have a source of light, a good source of light. You need a kidney dish, gallipot, and sterile glass. It's a sterile procedure. And with the procedure, the first thing you can do to a patient is to educate the patient about the procedure you're about to perform. So you show her the abnormal cervix, then the normal cervix. Then you tell her, if any lesion is seen, what will you do? And you will also explain the consequences of her actions or her choice to her. So if a lesion is seen and is not treated, it can lead to this cervical cancer, and eventually we will lose her life out of her decision or out of that. And if a lesion is seen earlier, or a lesion is seen and it is treated, she can also be on the safer side, because if it's treated, it means these viruses are dead and she is able to prevent herself from contracting these viruses. So the second is show her the bed. So after showing her the bed, the second thing you do is you position the patient in a electrotomy position. You will inspect the vulva. I told you this HPV virus can also cause vulval cancer. So you inspect the vulva, and you need it in your findings. So you inspect the vulva carefully. If there is any abnormal vulva or a normal vulva, you wear your gloves first. Then you take your speculum, apply the gel on it for easy entrance. So in place of the gel, you can use water to lubricate the speculum. You pass the speculum nicely into the vagina of the female. Then you will search for your cervix. You don't just lock the speculum once you've not seen the cervix. So you will search for the cervix and lock it. You secure the speculum very well so that it doesn't push out and will cause the patient to feel pain. So you secure the speculum nicely. Then first thing you can do after the passing of the speculum is you can clean the cervix, yes, to clean any discharges, prevent error reading during the lab test. So after that, you take the pap test first, followed by the HPV if the person actually wants you to take the HPV test. So afterwards, you dab the cervix with cotton swab containing acetic acid. You dab it on the cervix nicely. You dab. So after that, you wait for 2 to 3 minutes. Then you inspect the cervix. Were there any lesion or there are no lesions? So before the application of the acetic acid, you first inspect the cervix. Whether there is any leukoplakia, whether there is any polyps, whether there is any Nabotian cyst or erykoplakia or any other abnormalities before you dab the cervix with acetic acid. And you wait for 2 to 3 minutes before you can tell your findings. And after this application of the acetic acid, you can determine your transformation zone. So if there is any leukoplakia, you advise the patient to go in for the loop method, loop electrosurgical excision procedure. And if there is the Nabotian cyst, you tell the patient it will go by itself. So after application of acetic acid, you determine the TZ2. So afterwards, you take the speculum off nicely and gently in order not to hurt the patient, and you discard your sterile glass tube and you tell the patient if there is polyps, to tell the person to go and excise, and the bed is carbolized with chlorine solution. Not forgetting about this genital wart. That's why you have to inspect the vulva, the vagina, and the cervix. Because this genital wart, sometimes it can be on the vulva, sometimes it can be in the vagina. So when you pass the speculum, you have to inspect all these things before application of acetic acid. Then with the colposcopy finding, colposcopy is either adequate or not adequate. And you tell where it was. The cervix is red like the clock. Colposcopy adequate, TZ3 from 10 to 12 or 12 to 1 or 12 to 1. So you also add the transformation zone to it because it's very important we know the transformation zone. So you also tell the patient this one. Maybe there was an lesion and the patient said treated. So we treated it. When the treatment is done afresh, the patient can experience abnormal vaginal discharge, yes, for 2 to 3 weeks, but afterwards it's gone. And some sharp pains at her vaginal side and pelvic pain too. So the patient can also experience this and sometimes to fever and all those things. But if it is persistent, maybe after 2 months, 3 months, the person has to visit the hospital. Before a woman is screened, there are forms she fills before she's screened. And with the forms, they ask you a series of questions. These questions are just to know the mode of transmission and other details. The mode of transmission, your husband may have other wives or you have other husbands. So all too soon, this is the end of today's video. Don't forget to subscribe if you are new here so that you don't miss any video I post on my YouTube channel.